The maternal fetal dyad model and maternal authority in contemporary bioethics. The maternal fetal dyad model describes pregnancy as a relationship involving two morally significant entities, but only one autonomous patient, the pregnant individual. Chervenak and McCulloch emphasize that ethical maternal fetal medicine must be grounded in beneficence and respect for autonomy, with the fetus regarded as a patient only when the pregnant woman presents it for care and when intervention is expected to provide fetal benefit. This means the fetus does not possess independent moral status, but derives its patienthood entirely through the pregnant person's choices and clinical context, a point Chervenak and McCulloch stress repeatedly in defending their framework against. Critics like Lyely, emphasizing that the physician's obligations to the fetus must always be balanced with obligations to the pregnant woman's autonomy and well-being. The dyadic model therefore grounds maternal authority, not in dominance, but in the biological and ethical fact that every fetal intervention is simultaneously an intervention on her body. Because the fetus cannot express preferences or exercise decisional capacity, fetal interests must be interpreted by a competent decision-maker. Chervenak and McCulloch call this the ethical concept of the fetus as a patient, grounding how clinicians balance beneficence-based obligations to the fetus with autonomy-based obligations to the pregnant patient. This mirrors surrogate decision frameworks used for incapacitated patients, where surrogates may make profound end-of-life decisions such as withdrawing ventilatory support, refusing risky surgery, or declining antibiotics or tube feeding. However, Maggie Little and Anne Lyely have argued that ethical frameworks in pregnancy must also confront the broader problem of insufficient evidence and inadequate consideration of pregnant individuals in research, showing how neglecting pregnant people's unique position can itself cause harm and distort surrogate-style reasoning about fetal risks and benefits. Their work highlights that ethical decision-making in pregnancy must incorporate justice, equitable protection, and respect for pregnant people's interests, reinforcing the centrality of maternal authority. Pregnancy, however, introduces a critical structural difference that makes maternal autonomy even more foundational than typical surrogate frameworks allow. In ordinary surrogate situations, such as a comatose adult, a surrogate cannot consent to invasive procedures on another person's body for the patient's benefit. Chervenak and McCulloch's professional responsibility model explicitly rejects any rights-based framing that would pit mother against fetus, arguing that such models generate conceptual failures and clinical distortions. Instead, all obligations must be balanced in ways that respect maternal autonomy as a necessary constraint on fetal-oriented beneficence. Complementing this, Little and Lyely describe a persistent ethical mistake in treating pregnancy as a problem of excluding or bypassing the pregnant person. They argue that pregnant women must receive equitable respect and timely access to biomedical advances, not be relegated to passive vessels whose interests are sidelined for fetal considerations. This directly supports the dyad view. Only by recognizing the pregnant person as the primary subject of care can fetal interests be responsibly interpreted. At the same time, the dyad model explains why maternal decisions legitimately influence the fetus's future. Under Chervenak and McCulloch's professional responsibility model, the fetus becomes a patient only when the pregnant woman seeks care for it and when intervention can reasonably benefit it, placing her in a role analogous to a surrogate but with deeper moral authority, since she is both the decision maker and the bodily locus of any intervention. Meanwhile, Little and Lyely have shown that attempts to separate fetal and maternal interests conceptually, treating them as separate patients, misrepresent the lived reality and generate flawed policy and research ethics. They insist on frameworks that respect the interconnectedness of maternal and fetal welfare and reject treating pregnant people as detachable from fetal medical decisions. The result is an ethical alignment. The mother's authority is not optional or arbitrary, it is structurally and morally necessary. Thus, together, Chervenak and McCulloch's professional responsibility model and Little and Lyely's reproductive ethics scholarship converge in a shared conclusion. Maternal authority over fetal outcomes is ethically justified, clinically necessary, and structurally inherent to pregnancy itself. Through the dyad model, the pregnant individual remains the primary patient whose bodily integrity, autonomy, and informed judgment guide all fetal-relevant medical decisions, just as surrogate decision-makers do in other cases of profound incapacity, but with uniquely greater moral grounding due to the intimate physiological unity of pregnancy. Maternal authority in the maternal fetal dyad. Premise 1. All medical decisions about a patient must be made by the autonomous individual, whose body is the subject of the medical intervention. Premise 2. During pregnancy, any medical intervention intended to benefit the fetus is necessarily an intervention on the pregnant individual's body. Premise 3a being that cannot exercise decisional capacity, such as a fetus or a comatose patient, requires an empowered decision maker to determine its medical interests. Premise 4. No surrogate decision maker may authorize medical interventions that violate another person's bodily autonomy. Premise 5. Because fetal medical treatment occurs only through the pregnant individual's body, any fetal-directed intervention would require her autonomous consent and cannot override her bodily autonomy. Premise 6. Therefore, the pregnant individual is the only possible agent whose bodily autonomy and decisional authority can govern medical choices affecting fetal outcomes. Conclusion therefore, in the maternal fetal dyad, the pregnant individual necessarily possesses primary authority over medical decisions affecting the fetus, not as a surrogate for a separate patient, but as the sole autonomous patient whose bodily integrity is inseparable from all fetal relevant medical intervention. Motivating principles in the maternal fetal dyad argument 1. Bodily autonomy principle. The pregnant individual has exclusive authority over medical interventions involving her own body. Because all fetal directed treatments occur within her body, autonomy structurally grounds her authority too. Unity of intervention principle. Any medical procedure intended to benefit the fetus is simultaneously and unavoidably a procedure performed on the pregnant person. There is no separable fetal intervention. 3. Incapacity and proxy principle. A being without decisional capacity, for example, fetus, coma patient, requires another agent to interpret its interests. Decision-making thus defaults to a responsible, competent adult. 4. No third-party intrusion principle. No surrogate, guardian, physician, or state may authorize the use of another person's body for the benefit of an incapacitated individual. This principle prohibits overriding the pregnant person's bodily autonomy. 5. Dependency principle. The fetus is entirely physiologically dependent on the pregnant person, and its medical condition cannot be assessed or treated independently. This dependence grounds why the pregnant individual serves as the decision-making locus. 6. Beneficence within limits principle. Ethical obligations to benefit the fetus must always be balanced with respect for the pregnant individual's autonomy. No fetal benefit can ethically justify violating her bodily integrity. 7. Sole patient authority principle. Because the pregnant individual is the only autonomous patient involved in fetal care, she necessarily holds primary decision-making authority over all medically relevant choices affecting fetal outcomes.